So, respected senior doctors, my doctor friends, and former friends, I'm here to make a presentation on diabetes and management with a particular diabesity management with a particular focus on evidence-based findings. I thank Dr. G. Vijayakumar and Dr. Kannan for their kind introduction as well as invitation. My disclosures, what I'm going to do for another 15 minutes. Diabesity is a term used to describe the link between type 2 diabetes, obesity, and overweight. He has first coined the term diabesity in early 1970s. There are many drugs available for successful management of type 2, but the medical management of obesity is always problematic to clinicians. So bariatric surgery is invasive, unacceptable to many patients, expensive, sometimes associated with the long-term adverse health consequences. So offer an underutilized treatment plan for care of patients with the diabetes. Next is multifactorial. Obesity is a multifactorial disease with various phenotypes, clinical presentation, and treatment response. There is always an interaction between environmental factors and genetic factors. So body weight, that is determined by energy balance, which are chemical, genetic, inflammatory, and hormonal mechanisms. So we have inflammation hypothesis, where the circulating inflammatory markers play an important role with reference to insulin resistance. Lipid overflow hypothesis, where the lipid metabolites, they play an important role with reference to insulin resistance. And adipokine hypothesis, the adipokines resulting in insulin resistance and type 2. So the medical complications, Dr. Kannan has alluded nicely the complications as well as complications of obesity. So glycemic control, that is, we are looking into hyperglycemia management. That reduces the nephropathy, neuropathy, retinopathy, cardiovascular disease. On the other hand, weight reduction reduces the risk of so many metabolic conditions associated with the diabetes. So the progressive weight loss improves key measures of metabolic health in terms of improving beta cell function, insulin secretion, in terms of improving insulin action in the liver, in the skeletal muscles, as well as adipose tissue. Next is maintenance of weight loss is challenging. All the interventions listed below were diet-only intervention studies. Starting from the day 1 to the end of the study and during the follow-up, you can see there is a degrees response with reference to weight loss medication therapy. So weight management interventions, they're often followed by weight regain. So long-term persistence of hormonal adaptations to weight loss, especially that is, it led to increased appetite stimulating hormones and decreased appetite suppressing hormones. There is an imbalance between anorexigenic signals as well as orexigenic signals. So the body's physiological response to weight loss commonly leads to weight gain. So there is excessive secretion or signals related to ghrelin as well as subjective appetite, and there is reduced secretion of leptin, peptide YY, cholecystokinin, insulin as well as amylin. So weight loss alters the body's homeostatic system, favoring weight gain. So there is a change with reference to orexigenic stimulus. Next is we have the eating disorder. Next is changes with reference to nervous system activation, metabolism, as well as energy expenditure and anorexigenic signals. So there is an imbalance between energy intake as well as energy expenditure. Understanding the complexity of weight loss and its maintenance. So energy balance is normally regulated by the brain. The brain controls the appetite by regulating the 3 types of eating: homeostatic eating, hedonic eating, as well as the executive eating. So adaptation that reset the weight loss changes with reference to hormonal signals. So long-term approach to obesity management is required for maintaining weight loss. So comprehensive lifestyle approach is currently recommended to achieve with reference to healthy eating. Of course, Dr. Dharani is here. Continuous energy restriction. So if the patient is taking 1500 milligram, restrict the caloric intake by 300 to 500 milligram per day. So intermittent fasting or time-restricted feeding or aerobic exercise, progressive resistance training, as well as relaxation techniques. So the modest amounts of weight loss can lead to meaningful improvement in health. So diabetes prevention, diabetes remission. Next is improvement with reference to hypertension, dyslipidemia, as well as non-alcoholic fatty liver disease with reference to percentage of weight loss required for therapeutic benefits. So challenges in diabetes management. There is no clear evidence on the long-term and sustainable benefits of lifestyle intervention with reference to diabetes management. So the behavioral, physiological, and environmental factors often influence the sustainability of such interventions. So that is potential mechanisms of actions of individual anti-diabetic drug classes mediated through different organs in the body on diabetes and diabesity. So we have patient with diabesity presenting with the poor glycemic control. Can we initiate insulin or not? Because our primary aim is to achieve and maintain optimal levels of glycemic control. So in circumstances when immediate improvement in glycemic control is desirable, insulin should be commenced. Equally important is proper education, medical nutrition therapy, improvement of physical activity, right? Next is metformin. Metformin weight neutral agent, as well as it is associated with weight reduction also. And it is used with improvement in several insulin resistance directly or indirectly, especially in patients with the polycystic ovarian disease, GDM, non-alcoholic fatty liver disease, and cancer. Sulfonylureas, we know. Glycoside, glimepiride, and glyphosate. Treatment is associated with excessive weight gain. So we should be very careful. It can result in worsening of the diabesity. Pioglitazone is good. It's a powerful insulin sensitizer. It increases body weight. But patient with a non-alcoholic fatty liver disease, there is improvement. Next is DPP-4 inhibitor. That is weight neutral, and it can be safely prescribed, and the recommendations are for favoring this DPP-4. Next is the mechanism of actions of glucagon-like peptide 1. It acts on the satiety center, reduces the food intake, reduces the hunger, and very important thing, it also induces energy expenditure. So we have the GLP, the action mediated by GLP, delays gastric emptying, increases satiety. GIP also increases glucagon, so it induces lipolysis and energy expenditure. Next is glucagon. It increases energy expenditure, show marked weight loss as well as improvement in glycemic control, and decreases the liver fat. So GLP-1 receptor analog as anti-obesity medications, we have exentin-based and human GLP-1 analogs. And the recent advances in weight management, we have the semaglutide 2.4 milligram for weight management as well as other GLP-1 based components. So semaglutide, it acts on the hypothalamus. We have the arcuate nucleus. And we have the nucleus tractus solitarius as well as area postrema in the hindbrain, reduces the food intake, reduces energy intake, and also induces energy expenditure. Next is semaglutide 2.4 milligram. It improves the weight related, especially with reference to greater reduction of the waist circumference as well as weight. Next is with reference to improvement in glucose metabolism as well as reduction in the cardiovascular risk factors, namely the blood pressure as well as dyslipidemia. Next is GLP-1 based compounds in pipeline. So we have this dual, that is unimolecular single agonist. We have the exenatide liraglutide. We have the unimolecular dual agonist, a combination of GIP and GLP. We have the twin cretins, namely tirzepatide. So it improves the body weight as well as glycemic control as well as improvement with reference to cardiovascular factors. Novo Nordisk successfully completed cagrilintide phase 1 in combination with the semaglutide. Cagrilintide is nothing but amylin analog, which delays gastric emptying, induces satiety. So in combination with the semaglutide, there was 17.1% weight reduction, which none of the combinations have so far proven. 17.1% reduction in body weight over a period of 20 weeks in this particular combination therapy. Next is sodium glucose transporter. So it's a sodium glucose transporter with a favorable impact on body weight. It induces thermogenesis, brown adipose tissue. It also causes browning of white fat, apart from inducing glycosuria, natriuresis. So these are all the actions mediated by SGLT2 inhibitors. It induces glycosuria, natriuresis, caloric loss, weight loss, as well as improvement in the brown adipose tissue thermogenesis, as well as browning of white fat. Next is diabesity rationaling drug combinations. So monotherapy may not be adequate. Combination therapy. While choosing a combination therapy, there should not be worsening of diabesity. Very important. So metformin is the first line. what next after metformin, multiple agents, and it should be ideal with a weight loss potential and weight neutral to avoidance of worsening diabetes. So in patient with poorly controlled diabetes, so insulin with metformin and insulin with the GLP-1 receptor analog, insulin with metformin and SGLT2 inhibitors favorably improve, at the same time minimize the weight gain. So combination therapy. So combination of oral medications like metformin, DPP4 inhibitors and SGLT2 inhibitors. So combination of metformin, DPP4, metformin, SGLT2 or SGLT2, DPP4 and metformin combination. So this is an algorithm for glycemic management in patient with the diabetes. The first line therapy, metformin. Next is second line therapy, depending upon the patient's body mass index. So GLP-1 receptor analog, SGLT2 inhibitors or DPP4 when the BMI is more than 35. Between 30 to 35, SGLT2 inhibitors, DPP4 inhibitors, GLP-1 receptor analog. Between 25 and 30, we have metformin plus DPP4, pioglitazone and sulfonylurea. So the drugs and drug combinations. With reference to A1C reduction, weight loss, metformin, GLP, DPP4, SGLT2 and combination of metformin with the GLP, DPP4 and SGLT2 in terms of A1C reduction as well as weight loss. Next is further, what is the role of anti-obesity medications like orlistat, and we have the phentermine, and we have this combination with the topiramide, and we have the naltrexone and bupropion compound. So the indications it is given here. That is pharmacological. Next is FDA approved agents for long-term treatment of obesity. We have the liraglutide, we have the semaglutide and orlistat and other drugs. So what to do when targets are not achieved? Even with multiple drug therapy, glycemic control can be an issue in many patients with the diabetes. If the glycemic targets are not achieved, the clinician should always revisit the existing management plan as well as patient compliance and revise this plan as and when necessary. So, role of bariatric surgery, current international guidelines and consensus statement for Asian Indians based on IFSO, APC and our own society, that is Obesity Surgical Society of India, indication for bariatric surgery. Apart from indication for bariatric surgery, wherein we primarily refer our patient for weight reduction, there is one thing called metabolic surgery. Western population, BMI more than 30 kg. Indian population, BMI more than 27.5 kg with poor glycemic control despite appropriate medical treatment, that is bariatric surgery. These are the mechanisms of weight loss. One is restriction, another is malabsorption, another is maldigestion, and a combination of both. Restriction, that is small stomach. It sends signals via the vagus nerve to the hypothalamus and several parts of the brain. That in turn induces satiety, reduces food intake, hunger, and mediates weight loss. So bariatric surgery with reference to improvement in glycemic control. Again, the same point, that is immediate impact of surgery, potential mediators and effects on glucose homeostasis, caloric restriction, and sudden entry, that is enhanced nutrient and bile delivery to the mid-distal jejunum as well as ileum. Next is advances in genetic as well as diabetes management across syndromic and monogenic. So we have the syndromic obesity, Prader-Willi syndrome, BBS as well as Alström syndrome, and monogenic obesity with reference to the recessive variants, namely the leptin receptor, pro-opiomelanocortin as well as melanocortin 4. So we have the symptoms differ depending on the genetic diseases. And hyperphagia leads to severe early onset obesity. And this particular drug that reduces satiety as well as induces weight reduction. So in short, an evidence-based management algorithm for the management of diabetes. So lifestyle, medical nutrition therapy, behavioral modifications, metformin, GLP-1 receptor analog, as well as SGLT2 inhibitors. 10 sure thought things that work in obesity management, starting from seriousness up to bariatric surgery. So it has emerged as a major public health, and it is complex. There are no clear guidelines from different professional bodies, and rational combination of different anti-diabetic drugs will definitely help, and immediate and long-term treatment goals should be devised, and prompt and regular update of scientific evidence should also help clinicians. So last slide. please remember, this one runs on money and makes you fat. Cycling runs on fat and saves you money. Thank you very much.